Hi, today I'm going to update you on some COVID-19 information. As you know, COVID-19 is a global health problem without a specific treatment or vaccine. Human-to-human transmission is rapid. The efficacy of hydroxychloroquine, a prophylactic and therapeutic anti-malarial drug, could potentially shorten the time to recovery if you are hospitalized with COVID-19. But the data to support the use of hydroxychloroquine or chloroquine are limited and inconclusive. These anti-malarial drugs can cause some pretty significant side effects, like ventricular arrhythmia and cardiac toxicity. These medications do help patients with lupus and rheumatoid arthritis, which are common autoimmune conditions. Depleted supplies and hoarding by professionals have made these drugs difficult to procure. There is no data to support the use of pre-exposure prophylaxis with these medications to prevent COVID-19. There are no differences in mortality among those patients who did or did not take antibiotics or steroids to treat COVID-19. In contrast, high-dose IVIG, a polyclonal immunoglobulin from healthy donors, may seem to help decrease cytokine dysregulation, which is the main cause of acute respiratory distress syndrome, or ARDS, in patients with really more of an accelerated COVID-19 illness. IVIG, when given at the appropriate point in the disease process, could successfully block the progression of this cascade and improve outcomes. What about angiotensin receptor blockers and angiotensin-converting enzyme inhibitors, or otherwise known as RAS inhibitors as a group? ACE inhibitors and angiotensin receptor blockers are commonly used to treat hypertension. I have a lot of patients who take these on a daily basis to treat their hypertension. In a New England Journal of Medicine article from March 30th, hypertension was the most frequent coexisting condition in a study out of China looking at 1,099 patients who were hospitalized with COVID-19. Roughly 15% were on a RAS inhibitor. Age, more so than hypertension, seems to be emerging as the strongest predictor of COVID-related mortality. Next, I'm going to talk about the ACE2 enzyme, which is a key enzyme that degrades this vasoconstricting angiotensin 2 molecule to the vasodilating angiotensin 1 molecule. 15 human organs express this ACE2 enzyme. Studies have shown that the ACE inhibitors do not directly affect ACE2 activity. ACE2 activity was not higher among patients taking ACE inhibitors or angiotensin receptor blockers. ACE2 level, in addition, may not be a reliable indicator of the activity of the membrane-bound form of ACE2. In fact, losartan, which is a common angiotensin receptor blocker, is being tested as a possible treatment for COVID-19 patients who have not previously been on this medication. Clear potential harm related to the withdrawal of these ACE inhibitors and angiotensin receptor blockers is evident. They have established benefits in protecting not only the heart, but the kidneys. If patients are to suddenly stop taking these medications, it may risk clinical decompensation, especially in high-risk patients. Until further data are available, these RAS inhibitors should be continued in patients who are otherwise in stable condition. What about anti-inflammatory medications, or NSAIDs, like Moren, Advil, Aleve, ibuprofen, Celebrex? Uncertainty about these medications are being posted on social media and in the news. Reports claim that the use of these medications increase symptom severity and significantly worsen the condition. While NSAIDs do carry potential side effects like GI bleeding and increasing your blood pressure and have an adverse effect on the kidney if taken at high doses, there is no evidence to show that these drugs affect infection rates or worsen symptoms in patients with COVID-19. I hope this information helps. Stay tuned for more. Thank you.